Okay. So good evening, everyone, and thank you again, Anna, for that kind introduction. And so, as he said, I'm going to talk to you on care of a potential deceased donor in the ICU today. So hopefully this will run about 30 to 45 minutes. And at the end, you can ask questions, or even if you feel like you want to ask questions, Emil, that's fine. You can always stop and ask questions. So the objectives of this talk is to understand the pathophysiology of organ deterioration in a brain-dead donor, and to explain the interventions that need to be followed to optimize brain-dead donor before organ harvest. So we'll talk about these two main sessions during this talk. So a bit of an introduction. So brain dead is one entity, whereas somatic death, or the heart stops beating, is another entity. But what we have to appreciate is that all brain dead patients will eventually go into somatic death, or their hearts will stop beating at a moment. And if we do not do the correct management of any substandard management of the donor, that will result in a loss of 10 to 20% of organs. This, mind you, is in developed countries, not in ours, which might be much higher than this. So therefore, timely treatment of the donor is very crucial. So in order to prevent this organ loss, there are standardized donor management protocols that have been made, and we have adopted some of them to our country also. And this has actually shown to increase the number of retrieved organs in the best possible condition for the recipient. So we'll just talk about a case scenario where how we did organ preservation in this patient. So this was a 25-year-old motorcyclist who ran into a side post and hit his head on a wall, and immediately brought to the ED. And in the primary survey, his GPS was 3. And this was his CT. As you can see, there's a STH and a bit of contusion on the frontal brain. So we started neuroprotection, which involves we intubated this patient and ventilated, and we did sedation and paralysis as needed. This is all something called neuroprotection. We stop the brain from functioning so that it gets time to heal. And then we maintain the oxygen and carbon dioxide normal so that the brain gets perfused and it gets enough oxygen to heal. And the carbon dioxide we keep within this range so that there's no hyper or hypo perfusion of the brain, because the perfusion of the brain depends on the carbon dioxide level in the blood. And we maintain blood pressure so that adequate perfusion for that dying brain is maintained and the brain can recover. We kept him head up, so there's good venous drainage, and we kept the head in the neutral position again to maintain a good venous drainage. And we try to keep the sodium towards the high level by using hypertonic saline, and we avoided hypotonic solutions. I will explain why this is been done. And if there were anti-epileptics, we would, if there were seizures, we would start anti-epileptics. And we would try to maintain temperature within the normal range as much as possible. And also this patient ultimately ended up having a bifrontal craniectomy. And we continued the other ICU. So the patient was brought to the ICU, so we continued the supportive care in the ICU. So 24 hours later of doing this neuroprotection, this is the repeat CT. As you can see, there's a craniectomy done, but the brain here is bulging because there's so much profuse kind of cerebral edema. And actually, the actual CT showed that there was no white-gray demarcation. And when we looked at his pupils, they were non-reactive, 5 millimeters. And when we change the ventilator to see if the patient had any spontaneous breathing, he did not. So this was a clue for us to say that this patient could be brain dead. So how long should it take to test for brainstem functions? Well, there's no time limit given. As long as you're sure that their brain injury is so devastating that it's very unlikely that patient would survive from this. And you have given enough time for the brain to recover if there was any slightest possibility of recovery, that's the time where you would do the brainstem function. And in this patient, we did do the test, and which is a separate topic completely, so I'm not going to go through that. Anyway, so brainstem death was confirmed. And since he was a young chap with no comorbidities, we decided to proceed with organ donation. So all this time, we were trying to save this patient and to save the brain. But from this point onwards, as you may know, brainstem death is considered as death in worldwide, and it is so in Sri Lanka also. So legally, we are love to believe that this patient is dead from this point onwards after the brainstem test has been done. So there's no point in trying to save his brain or this patient, but of course the patient's organs are still working because the heart is still beating. So all the organs that can be transplanted need now support. So the management is going to change from patient or brain saving into organ preserving. So why do organs need preservation? Anybody in the audience would like to answer this? Why do they need preservation? Like, for example, if my heart is beating, I do not need to preserve my organs. But why do these people, these patients need organ preservation? If anybody wants to put in a word? Okay, with that silence, I will move on to my next slide. So I'll try to explain this very briefly. It's kind of a pathophysiology that is involved. So, you know, any organ, mind you, the kidney, the liver, the heart, any organ in the body, it's made out of cells. So the cell will produce energy to do it, whatever the function that is needed. So in order for that cell to do it, and as a group of cells, they do the function of an organ. So these cells, in order for these cells to do their work, they need to have a supply of what there are necessary things that they need to do their function, and also there is a demand on them. Whatever the function they have, that there's a demand. So any organ to do its function adequately or to the optimum, this oxygen supply and demand should be balanced. So the oxygen supply depends on the hemoglobin, the total body water, the blood pressure, the blood volume that we have. It comes to the cell and gives the oxygen. And all the cells, as you know, have mitochondria, and they would use this oxygen and the nutrients that is given, and they will produce ATP. In order to maintain the demand will be variable in the separate organs. For most of the time, it's the sodium potassium pump that needs the energy. You know, the cell membrane maintains the integrity of all the organs. So the cell membrane, in order to maintain that integrity, it needs a sodium potassium ATP pump. So for most of our energy is used for that. Apart from that, the muscle cell, we need energy for muscle contraction, and the glands in the body would need energy to secrete the secretions. The GI tract is the same, and the kidney, you know, the medulla and the cortex both use a lot of energy, because again, it is a main kind of an organ where your electrolytes are maintained against concentration gradient. So it needs a lot of energy. So as long as you keep this oxygen supply and demand in balance, that organ will work. So what happened in a brain dead patient? Let's just take a look at that. So in physiology, we explain this this principle called the Monro-Kennedy doctrine, where the brain is covered by this skull, which is a rigid structure, and the brain matter, the CSF and blood, they are all in kind of an integrity inside them. They communicate with each other to maintain the brain pressure within the normal range. But now, as you see, there is some insult here, maybe a hemorrhage, maybe infarction, some sort of an insult. And what happens is, because of that insult, the cells in that area will die off. And when it dies off, there's a bit of an edema that develops there. And that edema will cause this surrounding area, the penumbra, what we call it, to have an increased pressure. As a result, the arterial blood supply will be reduced to that area. As a result, that penumbra will die off. So this small area will slowly expand. We call it the initial injury, the primary injury. And with time, there's secondary injury, which causes this injury to like kind of expand in the brain. So now the brain does not have room to expand. So what does it do? It initially, so the brain, the arterial blood, the venous blood, and CSF is in harmony inside. And now there is edema or mass being developed. As a result, now it has to keep its intracranial pressure within the normal range. So what it does, it expels the venous blood and the CSF initially. So the pressure is still maintained within the normal range. But at a point when it goes up to about this size, the mass is so large, your venous blood and CSF has gone down a lot, and your arterial blood is also now getting compromised. So the penumbra is getting worse because your perfusion is now getting affected, and the brain no longer can maintain that pressure. So the pressure rises up very steeply here. And the only way to release that pressure, the brain, the skull only has this hole here, the foramen magnum. So it tries to push the brain matter. The next thing that it can push out is the brain matter. Everything else has been compromised to the maximum. So which is called coning, or kind of a terminal state in a brain dead patient. So what happens when these changes occur in the brain? So the moment the patient is brain dead, this vicious cycle starts happening inside the brain. So now the brain, because there is hypoxia, the body is trying to maintain perfusion to the brain. As a result, we get the Cushing's reflex. The pressure goes up and the cardiac inhibitory center gets stimulated, and it will cause a bradycardia, which is called the Cushing's reflex. And when the brain, the ICP goes up and up, because when the ICP goes up, in order to maintain your cerebral perfusion pressure, the mean arterial pressure has to go up. That's why the mean arterial pressure goes up. And at a point, it's so ischemic, there's a sympathetic storm kind of, all the autonomic reflexes starts up, and it causes a tachycardia. So there's a hypertension and tachycardia later on. And at the end, what happens is there is coning, as I mentioned here. So the medulla contains the vasomotor center, which is kind of a vital center in our body. And when that gets affected, when that hits the foramen magnum, it dies off. So all of us live with some sort of a vasomotor. There's constrictions of our vessels. That's how we maintain our blood pressure. But the moment the vasomotor center gets affected, the whole body goes into profound vasodilatation. As a result, the blood pressure starts dropping from that point onwards. So that is the main change that happens in the cardiovascular system. And also there are atrial and ventricular arrhythmias. Anything that happens with the brain will cause severe injury, will cause arrhythmia. There's a connection between the brain and the heart. And also there's something called neurogenic pulmonary edema, with the brain getting swollen. There's water filling up into the lungs. So in any patient, if we do not manage this correctly, you would inevitably see this. The brain dead patient on day one will later on have this cardiovascular deterioration. The moment there is cardiovascular deterioration, there will be reduced oxygen and blood supply to the organs that we are going to harvest. So this is the main problem that happens in this patient. And so that's about the cardiovascular system. I will move on to something that happens in the brain again. So now the brain is dead. As you can see, this is the usual blood flow to the brain. Yes, you can see to the angiogram. And in a brain dead patient, there is no blood flow because the ICP is so much so that blood flow cannot be maintained. As a result, there is no blood flow. So all these cortex and everything will start dying off. One vital such center is the pituitary. So mainly the posterior pituitary. And the posterior pituitary secretes ADH. So ADH will no longer be secreted. As a result, ADH is responsible for retaining water. So this patient will start losing water. And this is called diabetes insipidus. So we see this in patients who are brain dead. The anterior pituitary is relatively sparse because the blood supply, if you go back to your MBBS levels, you might remember they are different. But still, there is a kind of a relative reduction in the thyroxine levels and the cortisol levels as well, but not as so much as ADH. And also, we have seen that these patients will end up having hyperglycemia. Also, there is, because this brain secretes so many intermediates, that it will cause problems in the hematological system as well. These patients go into anemia, and there's a coagulopathy because of this thromboplasty and all that is being secreted from the brain. So I have kind of explained to you what happens in a nutshell, actually, what happens after brain death. It's a sequelae of events that will lead to deterioration of the other organs as well as time goes on. So inevitably, within 3 to 5 days, these patients will anyway die. They will go into somatic death. So physiological optimization of the potential brain dead donor, it's an active process. If we do not do something from day one, this pathophysiology will occur and we will lose those organs. So we have to escalate our treatment. Although it's a dead body legally, we actually have to escalate the treatment. And so, as I said, our therapy switches from patient care and brain care into organ care. And we want to restore the physiological and metabolic hemostasis of the transplantable somatic organs. So, unfortunately, what we have seen is many critical care staff have little experience with these changes and how to optimize these patients. So, if there is any patient, in our thought is in any patient who's deemed brain dead, that patient, if suitable, should be considered for organ donation until criteria are not fulfilled. It's a criteria of exclusion. All patients should be included for organ donation. As a result, initiation of optimization of the donor should be established as early as possible. So what do we do? So now we leave the brain alone. Now we go by organ. So anything that all the management in ICU usually goes by systems. So we target each system and we try to optimize it. So we will continue. So the patients will already be intubated. So we'll continue the ventilation and we have target oxygen. We have oxygen targets, which is a little bit lower than what we had for neuroprotection, if you remember earlier. So this is normal physiological oxygen requirement that we will be maintaining. And the carbon dioxide also, we will maintain normal physiological as if you're alive. And these are some ventilatory modes that I have mentioned also. So there's no difference between a patient who's alive and who's brain dead. And we use certain parameters to monitor whether our targets are being met. So we do blood gases, we do things called mixed venous oxygenation, and we try to maintain. So I'm not talking about patients who are undergoing lung retrieval, because if that is so, these respiratory targets will be much, much different. We are not doing lung heart transplant yet. So that is actually a very much of a challenge. So there are more things that have to be added in case of a lung heart transplant. Then, so as I said, the blood pressure will start dropping, and also these patients are hypovolemic because initially the initial insult will lead them to bleed a lot maybe, and then there's diabetes insipidus, and then the patient goes into surgery. There are a lot of fluid losses. So our first management of hypotension would be to start them on saline. So this could be either in terms of 0.9% saline or Hartmann, and our target MAP is now 65. So 65 is adequate for a living person to maintain perfusion to their organs. So that MAP is maintained for these brain dead donors as well. And in advanced, like not advanced actually, this is available in all ICUs currently with these monitors that we have. We do things called cardiac output monitoring. If you have that, you can use it again. So we use pulse pressure variation. That is, you just put an arterial line and look at the monitor to see whether the patient is fluid responsive. Because sometimes the problem is we don't know whether we have adequately fluid resuscitated. So we use these other parameters, advanced parameters to assess fluid assessment. And after the fluid assessment is complete or while it's going on, we can start a vasopressor. As I said, there's vasodilatation. So we have to artificially vasoconstrict. So what we use here, in contrary to the other situations where we use noradrenaline, we will be using vasopressin, because ADH and vasopressin, they go hand in hand. So there we know there is a reduction in the ADH levels. So IV vasopressin would be the best vasopressor to start here. Second line, you can go for noradrenaline. And if there is cardiac dysfunction, you can go for dobutamine also. And also we would start in this patient that we started IV methylprednisolone. So all patients who have undergone, who are planned to go for organ donation, we would start methylprednisolone. This is not just to replace the cortisol, it's mainly to do immune modulation. So your organs are at a better kind of a state for transplant. The immune reaction would be less and your organs would be optimized better. So IV methylprednisolone 1 gram we would be giving. And because the hypothalamus is dead now, as you know, thermoregulation is done by the hypothalamus, so that will be lost. And also your vasodilator. So all your body temperature will be lost to the peripheries. So you have to do actual warming. So warming can be done by using a warming blanket or using all your fluids warmed up and coming down on the AC. So you have to do active warming also. To a level that your temperature is maintained normal. Also, hypothermia is also not good. So you have to maintain normal temperature. And we continued NG feeds also. We do not stop NG feeds in brain dead patients, but then once nutrition, once asked me, why are you feeding a dead person? Or is it for nutrition value? More than the nutrition value, it maintains the integrity of the gut microbiome. So, you know, there are the gut is filled with microbes, and maintaining a feed will help to maintain the integrity of that lining. If that lining breaks down, all the microbes in the gut will get access into the bloodstream, which will lead to a septicemia. So we don't need that. So we maintain an NG feed. And there are a lot of investigations that are being done. Mainly this is done by the transplant team. They do matching, they do so much investigations to look for infections. So all that along with the transplant team, we actually, in our setup, we involve the transplant coordinator and the transplant team, and they come in and they will do their own kind of investigation and their management. So it's kind of a multidisciplinary kind of teamwork that's going on. And other care that we usually give for patients in ICU, pressure point care, eye care, bowel care is also being given to these patients. So what type of fluid? As I said, it depends on, I didn't say it exactly, it depends on the cilium electrolyte levels, the sugar levels, and the hemodynamics of the patient. So crystallized with balanced salt, if you have heard about this, balanced salt is something that is more physiological rather than 0.9% saline, which is not that much physiological compared to our serum. And so balanced salt is preferred, and this also to reduce hypernatremia. So I mentioned to you diabetes insipidus, where water is lost. As a result, the sodium levels in the body will go up. So in that case, it's always better to avoid 0.9% saline and go for a balanced salt solution where the sodium content is much less. So lactate ringer solution or half normal saline are frequently used in these cases. And the other problem by using 0.9% saline is that it leads to hyperchloremic acidosis, which might kind of damage the kidneys. But saying that, we do not avoid it completely. It's only on if we use combinations. It depends on the patient. I won't say you cannot use it. So you can use Hartmann's 0.9% saline, half normal saline in these patients. So 5% dextrose, we usually do not use it. It worsens the hyperglycemia, but in cases where there is hypoglycemia or if the situation is there is a need for it, you can use it. Otherwise, we usually generally do not include it as a routine kind of a maintenance fluid. Starches we avoid. Again, this is because there is evidence to show that it damages the kidney. And albumin, in hypertensive patients, you can use it 4% or 20%. But like compared to saline, it has not proven to have better outcome in terms of organ preservation. If you have it, you can use it, but keep in mind, it's quite expensive also. And the target blood pressure, as I said, is 65, that is 60 to 70. And with after fluid resuscitation, if it does not come to this level, you have to start vasopressin. And if the cardiac index is low, you can start dobutamine also. So they have compared like low blood pressure versus high blood pressure in people who are living. And as you can see, there's no difference between the outcome of high blood pressure versus low blood pressure. So there are no studies as such to say this in people who are dead, brain dead. But we have taken that same principle over to management of brain dead donors as well. So in order to maintain this blood pressure, the MAP, and maintain adequate fluid resuscitation, we would go to an extent of inserting lines. When the patient was alive, maybe we have not inserted, but now we might insert central lines, arterial lines, and continuous measurements of central venous pressure, the cardiac output. We might go to that extent. Why is this? Because one brain dead donor can save, I think, if you take all the organs, it would be more than 9 people. So it's a very precious kind of a management that we are doing. So we go to that extent to do all these to make sure that our organ preservation is done optimally. So if you look at a patient who's been optimized for organ donation, he might look like this. He might not look dead even. If when you come to the ICU, he might look like an alive person because all these pumps and machines would be connected to this patient. Then arrhythmia should be treated promptly, and tachyarrhythmia, you can use amiodarone or cardioversion, keeping in mind amiodarone is liver toxic, so you have to make sure that it does not harm the liver. And bradyarrhythmias, atropine is not useful because now the autonomic system is not functioning. When the brain is dying, the spinal cord dies off, and all the nerves will die off. So atropine works through the vagus, inhibiting the vagus. So it will not work usually. So you have to have drugs that would act directly on the heart, which are the beta sympathomimetics, which is adrenaline, isoprenaline, or maybe pacing. And ultimately, at the end, these patients will go into terminal arrhythmias. We call them peri-arrest arrhythmias, which are resistant to therapy. And they would go into cardiac arrest. Now, if you're like in a situation where you're almost at the point of harvesting the organ, you would actually continue CPR while the organ's been harvested. But make sure that you do not have, this is not a prolonged period, because the more the hypoxic the organs will get, the suboptimal their condition will be. And temperature management, as I said, you have to prevent hypothermia as early as possible. If temperature is less than 34 degrees, you start co-warming. Co-warming is when you give warm things inside the body, that is IV fluids or NG feeds. And for less levels of hypothermia, you can do surface warming by putting a blanket over them and reducing the temperature of the environment. And you have to make sure that the patient is normothermic before organ harvest. Then hormone therapy, as I said earlier, corticosteroids, high doses of corticosteroids may reduce brain death-induced inflammation and help to modulate the immune function, thereby improving donor organ quality. So the moment your brain death is confirmed, we give our first IV methylprednisolone dose. And also it helps in reducing your vasopressin requirement also. So yes, so methylprednisolone is the steroid that we use. So in our patient, at 12 hours after confirmation of death, the patient had a urine output of 1,300 ml with continuous output of 150 ml or more per hour. And the repeated sodium was 163. So what do you think this is? I don't know. What do you think?
Yeah, this patient is polyuric, isn't it? And sodium level is very high. So it's not good for the liver actually.
Not just the liver. It might be not good for any organ. The sodium rising inside the cell causes osmotic changes, and when you put this organ with high sodium into the new recipient, that would cause water shifts and cause edema in that organ. So actually, this patient has gone into DI. It's a clinical. Here clinically we have diagnosed that. So a clinical diagnosis of diabetes insipidus was made and desmopressin nasal puff. So desmopressin is an artificial ADH or vasopressin. So we can use that in these patients, and we have started that. So there is IV desmopressin also now available in our country, so that can be also used. In other countries, they have a pill also. But mainly what we do here is we use free water. There's a free water deficit because the patient has lost a lot of water. So we make a calculation of the free water and we replace that. And if that doesn't bring down the sodium, we have to start desmopressin also. So, and once you start a therapy, you have to monitor it. So we did serum sodium level 6 hourly and saw how it came down. And as I said, the water was replaced with NG water and 5% dextrose. And yes, and all you remember, if all your drugs are being you're using sodium chloride as your solute, you avoid that and use 5% dextrose to dissolve your drugs also. By the time of the retrieval, because retrieval takes time, although we confirm brain death, it takes about 1 or 2 days, if everything goes well, for the retrieval actually to happen. So we had some time to actually optimize and bring down the sodium to 150. Yes, so desmopressin, I said diabetes insipidus can be treated by replacement of crystal solution and by administration of desmopressin. And vasopressin can also be used as an alternative, because as I said, vasopressin is also an kind of an analog of ADH. Then, so we have to maintain our sugars between 140 to 180. Hyperglycemia again causes oxidative damage to the cells. So we have to make sure that our sugar levels are maintained. So we might have to go for an insulin algorithm also. Thyroxine is being used in other countries, as although I have read so. But in our setup, we do not use thyroxine. So they used IV thyroxine in some setups. Yes, and this is all done mainly for cardiac. If there is cardiac impairment, they have shown that thyroxine, because it has an inotropic effect, as well as its overall effect on metabolism, will improve the effect on the heart. So infections. Now, what we see is we use a lot of antibiotics in our country. That's the way we have been taught and the way that we are practicing continuously. But and also we have to remember that brain death is a vasodilatory kind of a situation, which is same for sepsis. So it might be difficult to kind of differentiate between the two. But saying that giving prophylactic antibiotics is not kind of recommended in brain dead patients. So in order to start an antimicrobial, you have to have evidence shown by at least culture or a rise in CRP or procalcitonin. And also remember that all these drugs that we use as antimicrobials can be nephrotoxic or even hepatotoxic. So the best way to manage infection is to prevent infection. That is by maintaining good hand hygiene, maintaining oral care, and we do something called the WAP bundle, that is to prevent respiratory infection. So keep the head of the bed, head side of the bed elevated, and make sure that if you have inserted lines, that you maintain complete kind of sterility when you're handling these lines, the catheters also. And if you don't need any cannulas or catheters, just remove them as soon as possible. So that's how we manage infections in these patients. But saying that if you do get an infection, you have to treat it aggressively also. Then hematology wise, as I said, they are prone to have anemia. So the hematocrit should be maintained 30%. So in order to make sure that your oxygen delivery to all the organs is adequate, so you might have to transfuse. But again, this is a dilemma, because that can cause immunological reaction after transplant. So make sure that you talk with your hematologist as well as your transplant team before you transfuse any blood products to these patients. And nutrition, as I said, we maintain a nutrition at in these patients, and for the reasons I've mentioned earlier, the microbiome is really important to have a balanced microbiome in these patients. So checklists and targets, let's see. So if we can have a checklist like this, which was maintained in the hospital that I worked in UK. So they have all this, everything I've said, they have kept it in this one page. So you just have to tick it after inserting the patient's name and all the identification details. Then organ by organ, they have given your targets, and everything that I mentioned earlier are like put in here. So yes, I did not mention about DVT prophylaxis. Yes, you can, and you have to like maintain low molecular weight heparin can be administered, because the ICH is no longer in your mind. We are not trying to preserve the brain anymore. Yes. And here are the other monitoring charts they maintain. So they make sure, like hourly or 2 hourly, they maintain these oxygen, the carbon dioxide, the MAP, CVP. So it's kind of like the ICU chart, but usually we do not maintain oxygenation, carbon dioxide charts separately, but here they do have those. And it's again, it's a separate chart that they have for these patients who are brain dead. Again, to make sure, because they take kind of the full benefit of a patient who's brain dead. They consider as kind of a very privilege to have to support these brain dead patients, so that they can save a lot of other lives. So now we talk about all the physiology, pathophysiology, or all these medicine, but then what about the family? So all these patients who are going to be brain dead, most of them will be young fellows, because road traffic accidents are the kind of the major contributor for brain death. And so this is going to be devastating for the family, because the patient was fine in the morning, and all of a sudden in the next day morning, we are saying that the patient is brain dead. So we have to, while doing, I know we have a lot of things to do for the patient to optimize this patient. There are a lot of meetings going on, but we have to make sure that the family is given enough time to grieve. And so we reduce visitation restrictions, but make sure that proper hygiene is maintained, so no infection is being carried to the patient. And we allow religious activities and beliefs, and we have to support the family. And talking about this brain dead situation to the family is also another challenge of its own. So usually what we do in our setup is I talk to the transplant coordinator, and the transplant coordinator and comes and talks to the family. I let them know about the clinical situation, and that it's very serious, and I let them know that they're brain dead also. But the donation part, I can actually mention it, but I leave it to the transplant coordinators. Yes, and the grieving ICU. So this is not a good it's not a comfortable situation for the ICU staff also. ICU staff, because one nurse is for one patient, they get attached their patients very frequently, and these are young patients, and they all of a sudden they see this well-built man come and die in front of them, and they see the family grieving. And so I have seen a tear or two in our nursing staff as well, after caring for these patients, especially when they are going to the theater for harvesting. So we have to make sure that our staff is also looked after. So having a briefing after the patient has left is also very important. And the final walk. So with all this optimization, we take the patient into the theater and hand over to the anesthetist and the surgeons. And after harvesting the organs in optimal conditions, at the end, they would switch off the ventilator. And the time of death would be the time when the first, there are 2 sets of brain tests being done initially, when the first test was completed. And after that, the patient would be taken for the remains will be taken to the respective places. So actually, yeah, I'll give the summary before we go into questions. So I just again want to reiterate that substandard management of the donor results in a loss of 10%, a considerable amount of loss of organs. And so therefore, timely treatment of the donor is very crucial. So there are standardized donor management protocols that have shown to increase the number of retrieved organs in the best possible condition. So yes, Sarma, so with that, I have actually come to the end of my talk. Are we open? Can we like have questions or?
Yeah, Anushka, thank you very much for your very informative lecture. Now there's time for some discussions. If you have any questions, please you can ask now, or you can put it in the chat box here. Meanwhile, Anushka, I have a question to ask from you. During the time of retrieval, when you come for some organ retrievals, I have noticed that there are most of these patients actually been on noradrenaline instead of vasopressin as the vasopressor. What do you think about that? Is there particular reasons for some of these patients to be on noradrenaline?
Yeah, I think it's the education of the staff that have been used. As I said, we are now converting to a nation where we are now giving more emphasis on organ donation and optimization of the brain dead donor. So we are in the process, as Madam Ramya is also here and Madam Angela. I think there are others also. The ministry is like trying to implement a program so everybody, not just in the central teaching hospitals, but everywhere in the country, are being educated about this physiology and the things that we need to do. Usually in ICU setup, the first line of vasopressors is noradrenaline. So that is the custom that we see. But not in my ICU, right? You didn't see anybody on noradrenaline with, yeah. So it's about education. We have to make sure that everybody knows what vasopressor to be used in case of a brainstem dead donor. So we have to educate our staff.
Certainly.
Yeah.
Another question, Anushka. So now I have come across some patients, the donors are actually febrile, and there's a kind of a documented infection, like a urinary tract infection, because most of these patients have been on urinary catheters for a long time when they're in ICUs. So what do you think about the organ retrieval in that kind of situations? Will that be safe? Because they are anyway on antibiotics.
Yeah.
What do you think about the safety of this organ retrieval in that situation?
So that's a difficult question to answer, Avna. If anybody else in the audience can also help me out, what we do usually when this, because again, this is our country in Sri Lanka, we have misused, overused our antibiotics. As a result, we are harboring so many microbes in our ICUs and the hospital setup. As a result, within 1 or 2 days, everybody ends up having a hospital-acquired infection, and most of them are even multi-drug resistant. So what we do is we send the cultures and we start antibiotics and we get the microbiology opinion for the best antibiotic. But as you said, now taking that organ and transplanting it in a patient who does not have an infection and making that patient to putting him at risk of sepsis because of this organ is kind of a very arguable situation. So again, as I said, this is a multidisciplinary team approach. So if there is an infection, we always talk with the transplant surgeon, because there's no yes or no answer for this. If we can't refuse the organ because we are so sparse of organs, we do not get any of organs, and we can't take it without any risk because there's an infection. So ultimately what happens is we come to a decision, like a consensus between the whole team, including the microbiologist, and then we transplant or just reject it. So yeah, that's my view. What about you? What do you think?
Yeah, it's very debatable. I feel that I had actually retrieved such a patient once and used the kidneys, but not the liver. So anyway, there was no much problem actually after the transplant.
Okay.
So we anyway cover up with some high antibiotics, and then things went quite okay.
Yeah. Especially when you're immunocompromising him afterwards with your
certainly.
Yeah, exactly. So debatable area.
Yeah, Anushka, we have actually a comment here in the chat box that we use NG-thyroxine in neurosurgery unit in Colombo. How's that? Do you agree with that? NG-thyroxine.
NG-thyroxine, okay. The guideline mentions IV thyroxine, but if the gut is working, I don't think there's any thing that you can't say against it. Up to now, in my practice, I have not used it. Whoever has made that comment, uh, if they can explain, have they
I
seen
think
any?
Manjula Kuratna.
Yeah, madam.
She can
So,
speak out.
yeah, madam. Have you like seen something, the outcome better of these organs, or is madam there?
Not quite sure.
Okay. So again, Aruna,
Yeah.
this is the practice of the developed world to use IV thyroxine as an infusion, and whether there is a difference between the outcome in patients who have used thyroxine and who have not used thyroxine, as also IV thyroxine against oral thyroxine, the outcome of the organs, we don't know. There is no solid evidence. So overall, if you, I think there's no harm in giving it also. So I think you can give it, but I'm not in a position to actually say whether it's correct or not. Yeah.
Okay. Anushka, now you said that you're using NG water and also 5% dextrose. Is there a particular regime as to how we should go by? Like, rate that you have to run at?
Yeah. So there's a formula. If you know the water deficit formula, so we make a correction. Like if it's 165, we make a correction up to 150. So so there's when you put that formula in, it will give you the amount of water in liters that you need to correct that sodium from 165 to 150 actually. So we have to do that in within 48 hours. So what we do is we divide that in 48 hours and we give that. So per hour we get an infusion rate. So how much we give for each patient is individualized. I can't tell this amount for this patient. And also we do not just rely on this formula. We repeat the sodium in 6 hours and see. So you expect a reduction, at least about 1 or 2 millimoles of reduction. If that is not seen and it is going further high, that means that water replacement itself by itself is not enough. Then you might have to go for a pharmacological management. There are resistant cases I have seen, even in our ICU. Sometimes, no matter how much of water that we give and how much of desmopressin we give, the sodium keeps on rising. So it's a bit of a challenge managing this sodium.
Certainly.
Yeah.
Okay. Do you have any other questions from the audience, please?
Anushka.
Yes, ma'am.
Thank you very much. Anyway, as always, very clear lecture. Your voice and everything slides very precise, and must appreciate that first. And must appreciate the crowd in spite of a very interesting match. The people are listening to you. Yes, Anushka, I have one, question. As you said, yes, the education is not enough, including the medical officers. The value of this organ donation or organ preservation is not gone to the medical medical officers or including consultants, I must say. It's not, not adequate, and still they are not enthusiastic because probably they don't go into the depth of this, this national issue. That is also, I think that is one of the reasons. The other reason is, when you all are talking about the vasopressin, Anushka, vasopressin is not available in certain centers. So that is one of the main reasons why people continue on adrenaline. That is also another reason. And this diagnosis of brain death also not happening that often, not that quickly,
Yeah.
That is also, the decision taking. You have to take that decision when the brain is not recoverable. That decision should be taken. No, that decision is always delayed. That is also another reason to continue this noradrenaline. That's what I see. I would ask you a question. I don't know whether you can answer. Now, we are wasting a lot of organs probably at the E2 levels and maybe at the ward levels. No.
Yeah.
When the facilities are obviously suboptimal, what do you suggest?
You mean, madam?
That you are talking about the ideal management.
To have
What
management.
what aspects can we compromise for those patients? I'm just asking because I want to know.
Instead of taking them into the ICU, you mean?
Yes,
How to
yes,
manage them
yes.
in the ward setup and the ETU.
Because it very often it happen,
Mhm.
and I don't know. I personally believe we are wasting a lot of organs. You know the availability of ICU beds,
Yeah, that's
the
true.
situation. So what
Yeah.
do you suggest?
Yeah. The
Or
main
what do
issue
you
is the
recommend?
ventilation. So whether we can do ventilation at a level of ETU and ETU in for a long run and in
ETU,
the
of course,
ward
much
setup.
better than the wards. Yes.
Yeah. So wards, of course, you are just putting them on a portable ventilator and not monitoring any kind of a parameter. Then, madam, so first thing is you can't miss it. If we can have kind of an ICU team that if the wards are like
You mean
informing
the
the
outreach team?
ICU, like an outreach team, to inform the outreach team that there is a patient who's intubated with possible kind of a devastating brain injury. If the ICU team can go, the outreach team can go there. And we have done actually brain death confirmation in the ward setup. So you can do that in the ward setup, but then at least have a HDU level or some place where you can monitor at least the ventilation and the cardiovascular parameters. You have to have some kind of a specialized area. It's very, very difficult to I don't feel like it's very easy to manage them in the ward setting. So at least have a specialized area, not the ICU maybe a step down area, at least an HDU. If you can have with a few ventilators and a few monitors, and that with a few nurses who are trained in specialized care. I
You
don't.
mean only for this purpose you are suggesting?
That also would be like a waste of maybe in a HDU that you have in the hospital itself. If you can spare a bed at one time, there will be not more than one brain dead patient at especially in our hospitals, not the neurosurgery, but in our hospital, there will be one patient at a time, at a particular given time.
Yeah.
For HDU, maybe if we allow one bed for such patient, that would be it. What I see in our ward settings are these patients who have this spontaneous ICHs who come to the medical wards. They die off without even realizing that the patients are brain dead. If they were brain dead,
That's
we
true.
would have actually made a room for in the ICU and taken up, but we don't even know that that there are such patients in the ward setting. So if that level also they are, it's because they are not aware. If they knew that this could be a possible donor, they would have let us know. So education of those medical teams as well, apart from surgical, would help. So if they let us know and we have a little bit of a specialized place, I think we can make a compromise and try to optimize patients there. What do
At
you
least
think, madam?
no, at least kidneys can be taken. No, I don't know. If Visakha or somebody who who knows about this subject, I prefer to answer rather than me. I mean,
You mean about the liver?
Ramya, I of course feel it's going to be very tough to do it in a border HDU scenario. Because monitoring of electrolytes, gases, those have to go very closely.
possible, yeah.
We cannot retrieve organs if these are deranged. I think I personally think you need an ICU for this kind of thing. It's very difficult.
Yeah, now the spectrum is so wide now. They're talking about the other tissues as well. No, it will come in the future about the heart valves and the tendons and
The other things, right? Yeah.
other things
You're
and
like
skin.
thinking in
skin and
lines of skin bones and
yeah.
eyes and things. It's probably okay, but when it comes to the internal organs, I think it's a bit tough.
Even for kidneys, no?
Yes, even for the kidneys.
Actually, madam, I have my own personal experience. I had once a casualty and brain death patient, and I was trying to use these organs of this patient, quite young patient. and I used a portable ventilator in the ward setup and kept the patient alive for potentially 24 hours, but we couldn't go beyond that because by the time we got the recipients and everything, so it was too late. It's not something practical.
Madam, Bhagya here.
Yes, Bhagya.
If you are serious about transplant, we need to make sure that the donated organs are in optimal condition. And to maintain the donor so that we get optimal organs, we need to have basic minimum facilities, and that's found only in ICU. So I don't think we can compromise on that. There has to be they have to be managed in ICU, and wherever possible, we need to get these patients in ICU if we want good organs. Otherwise, it's just going to be a waste transplanting suboptimal organs and then struggling with the patient.
No, lot of places, Bhagya, when neurosurgeons are there, they transfer patients, right? And then when they diagnose irreversible brain, injury, but they don't proceed afterwards. The most of the patients from the E2, they send them back to the previous station. That is, the bed will be wasted, the transport, everything. Resources will be wasted, no? So I'm talking about that category mainly. Even our NSU, I know Manjula, I'm happy that Manjula is here in that. Here in this, the ETU, simply because they don't have beds in the NSU, the patients are turning back to the previous stations after confirmation of irreversible brain injury. They don't confirm brain death. The neurosurgeons, they just say the irreversible brain injury, that's it. And, that's it. I'm talking about that.
Madam, I think that has to be
happening at Karapitia, everywhere. Kurunegala, the all places where neurosurgeons are available. Yes, I'm talking about that category. How can we catch that group?
And I feel that it has to be a policy decision where if there is a brain dead or potentially brain dead donor, that they have to be given priority. I know there is a shortage of ICU beds all over, but if it has to, I think, come from the ministry as a policy statement that these patients have to be given priority for at least 48 hours.
And also maybe a lot of education, isn't it, of the people involved?
Yeah.
Any other questions to be discussed?
One more question, sorry. Now, regarding this, the family, Anushka, I don't think you should completely hand over this job to the transplant coordinator, is correct? Because family, they trust you. They gave the patient to you. Okay? It is definitely you should start this counseling part. Transplant coordinator should get involved. In Sri Lankan setup, mainly the consultant should get involved because transplant coordinators are, all are medical officers now.
Yes.
So I think more than 75% of the work is yours. ICU in charge consultant or the primary consultant.
Yeah, that's true. That's true. This I think the practice is from I think it's from UK. Usually, but they are, of course, they are very much trained on doing this. So the ICU, the consultant did. They suggested there is a possibility, but then afterwards they just managed the patient and they did not get involved in the transplant, the actual transplant process. Yeah, but as you said, we can. Yeah, I think there is no conflict of interest as there is no. I don't think so. No, I mean as the treating.
It's not. The convey the. Maybe I don't know. It's not conflict of interest. You say that, to tell the relatives that you have given the consent for this.
Yeah.
Right? Then they trust the system, no?
Yeah.
Rather than a completely outsider coming and talking to the family.
Yeah.
Especially in our setup,
Mm.
they trust you, no?
Mm.
Because you are the one who manage the patient.
I
Yes.
suppose
And
one of the
luckily-
disadvantages we have is that we have medical officers as transplant coordinators. If it
Yeah,
were
no
lay
one is
people,
thinking.
no, if it
Yeah.
were lay people, I think their rapport with the others would be much better.
You mean
Now,
not
normally in other
medical
countries,
officers.
in Anushka, in other countries, it's lay people, isn't it?
Yeah, the coordinator is actually specialized, not lay, madam. It was a
It's
specialized.
not a medical person, no.
No, yeah, it's a
It's never a
nurse.
medical person.
Yeah.
It's another a trained person, somebody trained,
Yeah.
but not a medical person.
Yes.
So I wonder whether that kind of person would have more of a rapport with the patients than a doctor.
Maybe, yes. Anyway, we have to address this issue with the Sri Lankan context.
Yeah,
Yeah. We have long way to go to train, This has to
As
be
far as I
very
know,
good.
there are sort of very well organized kind of transplant coordinators widespread throughout the country. And they are
Yes,
being
yes.
trained also.
About 180 or nearly 200 transplant coordinators are there.
Yeah, madam. I think as far as we know that there
Yeah,
are
some of them are very good. Only thing now they
Yeah.
are doing a voluntary job. They are doing something else also. They are not, doing only this job. So
Yeah.
then you can understand the situation, and they are, most of them are on transfer orders, and then the new person is coming. It happens. Anyway, we are
Yes.
trying our best to, get, transplant coordinators as such that they don't have anything else. They have only this job.
Okay.